wanting thalidomide, they don't have thalidomide. So sometimes I have to give some of these friends, when they come to Bombay for a meeting or somewhere we meet, I part away with some thalidomide. Though officially it is not allowed, but in the best interest of the patients. We saved some of these patients. Just before I came, Dr. Jagaukar had sent a patient virtually on the deathbed. This was in his private setup, and then he gave a call, and then I had to go and see the patient, and then we put him on steroids and virtually weaned him off from the jaws of death. And therefore, I find that it has been excellent. We are writing a case report on that. So these are several examples are there which have been the beneficiaries of thalidomide. This is another lady, again gave steroids. I don't give thalidomide as a first line. Give steroids and then watch and then see whether they are happy with that. But then if it keeps on coming and then bothering, then we'll have to resort to this. The precautions, like you are already aware, the contraceptive methods, the pregnancy test has to be done, and so many other factors will have to be taken into account. Why I am saying this is a young girl. Again, you see the age, it is 17 years. If you see the face, she was bloated with steroids, pumped with steroids before she was referred to us. And this is again a case from a place called Bhiwandi in Thane district, which is again 80 kilometers. And this was the status when she came. Severe ulcerative, virtually crying every day in and day out. I had the parents again, a 10th standard girl could not give her 10th standard exams, had to drop off from the exams, skipped 1 year, and virtually 1 year she was in miserable pain because of this reaction bothering her, severe necrotic ulcerative pustular reaction. Treated already with steroids, so I have left with no choice. I had to give thalidomide. And be strictly vigilant under hospitalized care. And then even that also was not working. Then we had to resort to methotrexate, injectable initially and thereafter well maintained on oral methotrexate. So these are some of the intractable reactions, and we will have to look into this armamentarium of these drugs. These are some of the examples of prednisolone on clofazimine. I just want to highlight this is a case where you see an ulcerative ENL reactions, mind you, not treated with thalidomide, but clofazimine. So clofazimine in high dose, you can see it helps in type 2 reaction. Even ulcerative reactions can help. But you need a stock of clofazimine, but that often doesn't come from the government side, so we have to buy it and then make it available through local purchase. Yeah. Now, the silent nerve damage. Some of these examples you see, this is a foot drop. Foot drop again of a short period, short duration. And here you will find in 2011 when we spotted this patient, and then after prednisolone and physiotherapy, you could reverse the foot drop. So nerve damage can be prevented, can be reversed, provided steroids, you pick it up early and then treat them with aggressive steroids. I think these are some of the examples, and then these are some case reports about azathioprine, cyclosporine, and things like that. But the message from this is that there is azathioprine or even cyclosporine as an immunosuppressive has not been helpful, though in stray cases it may work. You may find its usefulness in some of these. Methotrexate has to be tried. Then biologics, there have been very few case reports, plasma exchange and things like that. Then the JALMA people tried the pulse therapy with dexamethasone, betamethasone, and for cyclic management.
Topic or subject when we are dealing with Hansen's disease, everything revolves around damage to the nerves. So asking why is it important is like asking breathing, why is it important to live? So I think a senior scientist and a researcher like Dr. Vanaja Shetty would throw more light It's probably the topic was given keeping in mind that clinicians have a very superficial knowledge of what's happening in the nerve. And it is researchers, scientists, senior people like Dr. Vanaja who probably will throw some light so that we understand the nerve pathology better. Dr. Vanaja is a native of Udupi by birth, and I assume after her basic education she traveled to Bombay for a BSc, MSc and PhD which she got from Bombay University. It will be injustice if I don't mention a few of her achievements because most of it was put up on the screen. Her area of specialization is the basic and applied research in field of burns and leprosy, and she has done a lot of work in the evolution of the mechanism of nerve damage, development of experimental models to understand nerve damage, specialized in light and ultrastructural morphology and morphometry and immunology, and has got a vast experience with clinical and histopathological aspects of leprosy. She has held numerous posts like the Vice President of Indian Association of Leprologists, Faculty of Life Sciences, she's a panel of referees, member of the Indian Association of Leprosy, and a lot of other important posts which deals with leprosy and its sequelae. She is also the faculty for Leprosy Training Service at the Directorate of Health in Pune. She's been awarded the Jalma Trust Fund Oration Award in 1997. And the major projects undertaken at the Foundation for Medical Research are again vast, some of which are with the Indian Council of Medical Research, the Royal Tropical Institute of the Netherlands, the Government of Maharashtra, the Swiss EMUS Leprosy Relief Work in India, Tata Education Trust Mumbai, and also the Department of Science and Technology in New Delhi. She's got nearly about 93 or near about 100 publications in peer-reviewed journals. And who else would talk or throw light on the neuropathology of leprosy other than Dr. Vanaja Shetty? Welcome, madam.
Thank you, sir, for a very kind introduction. And at the onset, I would like to congratulate Fadamullah Medical College for their excellent achievements for the last so many years and celebrating their Golden Jubilee. And also the Department of Dermatology for calling for this important CME program, which I am sure will go a long way in the minds of new medical graduates who will be stepping on to and then doing practice in the field of leprosy. So as it is one of the, I think, hindering that thing that had come, or the declaration of elimination of leprosy, though it had positive impact on the many fields and things, but as far as the mindset, or there are certain negative impact of this particular declaration of elimination of leprosy is that it had hindered the main research programs, and then it had also curtailed funding. So that has also, I would say, it had eliminated research more than the leprosy in the field of leprosy. Though it is a research program that got eliminated rather than leprosy by itself. I would like to thank the organizers for inviting me, giving me this chance to talk on neuropathology of Hansen's disease. Why is it important? As rightly said by the chairperson, it's not that nobody knows that it is important, that I would like to emphasize and put more emphasis on, and then bring it to your notice, that the importance of this particular topic in dealing with leprosy. And Dr. Pai has already mentioned that every field and everything, every problem that you face with leprosy is because of neural damage. And then if you can stop that, if you can detect at an early stage, then probably we can, almost stop all the problems that are associated with leprosy. That is important. So that is why we have to understand as to how to detect early and how to prevent nerve damage in leprosy. So to this effect, I would like to bring some important points to your mind, put before you to say, what are the important aspects of leprosy neuropathy and how you can prevent and how you can control it. my order of presentation I would like to place before you. And I want to talk about a little bit of historical background. As we rightly said, it is nothing new, but what is right from 1880s, 1840s, it is known that leprosy is a neurological disorder. So I would like to touch upon the key historical points and the complications of leprous neuropathy, epidemiology of nerve damage, immunological and clinical spectrum of leprosy, and touch also on the clinical and pathological features of nerve in leprosy, differential diagnosis of neurological lesions, nerve function assessment and tools, and then what is take-home message. As early as 1848, it is Danielson and Boeck who said nervous system in general was the seat of leprosy pathology. Leprosy is probably the only disease known which is confined to peripheral nerves, said Carter H.V. is the professor of anatomy from Grant Medical College in Mumbai. Neuropathy occurs in all disease subtypes. There is no non-neural leprosy, says Dr. Khanolkar, is a pathologist from Mumbai in 1951. Leprosy would have been an innocuous disease but for the involvement of peripheral nerves. Fear of leprosy is fear of unsightly deformities so typical of this disease. It is necessary, therefore, to look into the causes of the deformities with the hope that better understanding may enable us to prevent or minimize them, says Dr. N.H. Antia. He is one of the renowned plastic surgeons from Mumbai, again, from Grant Medical College, who has spent best part of his life correcting facial and deformities of hands and feet for leprosy patients. Now, this is you must be all, aware of this picture that comes from Gray's Anatomy. This is Carter's dissection showing enlargement of leprous ulnar and median nerve in hand. You can see the sites of thickening that he has very beautifully illustrated in his anatomical dissection. It also shows leprosy is an intraneural plexus and how the caliber changes from point to point, and the dissemination of leprosy infection is known from proximal to distal segment. And the sites of enlargements of the nerve has also been beautifully demonstrated as early as 1858. This is Sunder's schematic diagram to show that leprosy is a distoproximal infection that spreads through the neural plexus. And the lower figure is to show the inflammation of the nerve that you see, heavy infiltrated nerve, the total destruction of the neural parenchyma, and probably fairly better preserved nerve fascicle in a skin lesion in a BT leprosy patient. Now, what are the complications which Dr. Pai has already highlighted? Secondary infection due to recurrent injuries to limbs, so soft tissue scarring. The soft tissue leads to soft tissue scarring, osteomyelitis, absorption of the digits, and so on, which is all known to you. Chronically infected plantar ulcers in type 1 reaction and type 2 reaction, secondary amyloidosis, malignant transformations, myositis, vanucolitis involving hands and feet, uveitis, impaired corneal sensation, blindness, chronic neuropathic pain defined as pain caused by a lesion or disease of some somatosensory system. These are complications of leprosy which probably you almost would be facing day in and day out. Talking about the epidemiology of nerve damage, 2 to 3 million disabled leprosy patients globally have been recorded. 1 million in India, that makes the PR of 10 per 10,000. Deformity among new patients in India is grade 1 is 5.1% and grade 2 is 4.6%, that is 2014 and 15 figure. The incidence of neuropathy in MB leprosy is 3 to 7-fold higher than PB leprosy. That is also a well-known fact. A recent study done in parts of Maharashtra by us records that NFI, that is not D1, it's G1 plus G2 is around 25%. Out of 5 and 7 patients which we have evaluated who were released from treatment between March 2005 and April 2010, had 25% of them had deformities, grade 1 plus 2 together. That shows the depth of, problem, which is probably much higher than what is being quoted or recorded by the WHO figure. Now, spectrum of leprosy, the disease of leprosy is probably one of the finest examples of same bacteria causing a whole spectrum of disease in human being. That's the beauty of the whole disease by itself. You have the tuberculoid end of the spectrum, you have lepromatous end of the spectrum. With one end you have high cell mediated immunity, and we have very little or low cell mediated immunity with no or very few bacterial load on one end to very high bacterial load on the other end. So entire spectrum is, and also the immunological response and cytokine responses are extremely in a polar ends are very different from each other. So, and nerve damage, you would see that it is along the entire spectrum of leprosy from TC to BT. Maybe there is difference in extent and the type of damage, but there is nerve damage in the entire spectrum of leprosy. And the reactions of both type 1 and type 2 add gravity or intensity to the ongoing reaction that is caused by the disease process by itself. Every clinical form of leprosy involves to a greater or a lesser extent the peripheral nerves. Nerve destruction is more rapid and more severe in the tuberculoid end of the spectrum. I would like to demonstrate few slides to you, giving the pathological spectrum various in different aspects of leprosy and the clinical presentations of leprosy along the spectrum. These are important in early detection and clinical and surgical management of neuropathy. If you understand the funda of pathological aspects of leprosy, would be very useful for you to handle the leprosy patients when you come across. Along the TT spectrum, the nerve damage or the presentation is rather asymmetrical, enlargement of single or few nerves. You may find damage to small sensory and autonomic nerves, which leads to hyposthesia and anhidrosis. Marked nerve damage can lead to clawing of hand and wrist drop. It is very common in TT leprosy, and whereas in LN leprosy, the nerve damage is slow and progressive, bilaterally symmetrical, and distal polyneuropathy is very common. Damage to small dermal sensory and autonomic nerves lead to glove and stocking type of anesthesia. So we generally tend to see more diffuse glove and stocking type of anesthesia on the lepromatous end as compared to tuberculoid end. In the borderline spectrum is usually irregular and asymmetrical neuropathy. Damage to the small and dermal sensory and autonomic fibers lead to hyposthesia and anhidrosis. Multiple affected nerves result in deformity to hands and feet. Some of the histopathological demonstration of nerves in leprosy that you see in this particular demonstration, you see the tuberculoid granuloma, extensive destruction of the neural parenchyma with the giant cell present here, the arrow, and dense lymphocytic infiltration which is covering the perineural and destructing the perineural consort. The perineural area. As compared, this is a BL leprosy nerve in a dermal lesion. You can see fairly well preserved wavy appearance of the nerve. Nerve is rather appear more or less normal as compared. There is a peripheral infiltrate that surrounds the dermal nerve.